Right, and there you have it, those particular pertinent figures from the year 2000 to 2021. It has claimed the lives of 11.7 million people from 2 billion cases, and we'll be diving into these particular numbers and what they mean. But real quick, let me introduce the guest this morning, Dr. Suma Kulkarni, General Practitioner from the White Oak Medical Center. Very good morning to you.
Good morning.
Thank you for coming through.
Absolute pleasure.
And Judith Otele, Case Management Manager, NHIF.
Good morning.
Uko salama?
Uko poa sana.
Right. Both of you are looking lovely this morning.
Thank you so much. You also look handsome.
Okay. It is World Malaria Day, Doctor. And, these particular numbers we were, looking at earlier, what do they mean? Have an analysis of it. From the year 2000 to 2021, has claimed the lives of 11.7 million from 2 billion cases. Read through these particular numbers for us.
So what we are seeing is that whenever you're seeing a statistic, you're trying to see if it's an upward trend or a downward trend.
Okay.
So what we're seeing in Kenya is that it's going on a downward trend. Like in the last decade, imagine 11% of the population. Like if you were to take the numbers, like 100 people in Kenya, what we're trying to say is 11 were infected with malaria. Now it's reduced to 6. So that's a very significant improvement to say that whatever we are doing, the intervention strategies, whatever policies we are implementing, whatever is being done at the ground level, it's working. That's what we're getting at. Mm-hmm. But having said that, it is not completely eliminated. That's where the challenge is. What makes malaria so difficult to eliminate? So Kenya malaria strategy, I think it was implemented in 2019. It's yet to be wrapped up by 2023, 5-year plan. So what did we intend? What was the goal of that strategy? It was that we would reduce the statistic in 2016, let's say the number of cases in 2016, to be reduced by 75%. And eventually the ultimate goal is by 2030, we are looking at possibly eliminating 90% of these cases. So in Kenya, the statistic is, let's say, 3.5 million clinical cases, new clinical cases, right? And how many of them are dying? Close to 11,000 are dying due to malaria. That's the latest statistic that we have. So what we're trying to hope is that this number reaches 0. That's what elimination means. Elimination is 0 cases.
Sorry to cut short. 0 cases by when?
2030.
Okay.
If not 0, at least 90% reduction in the number of cases.
Right. So
you need to actually do it for 3 consecutive years that you don't record a case. That's when WHO gives you that certificate that you've reached elimination.
Right. So, and Otele, speaking of from an insurance point of view, do you get many of these cases of malaria as frequently? And looking back, she talks about there has been a reduction. So you can take us back over the years. How was it in maybe 2000 and how is it right now? These particular cases, the recording of these cases.
Thank you so much. Yeah, in terms of from financial perspective, because that's how I'll speak about. Mm-hmm. And when I speak about from financial perspective, I'm not going to speak at the global picture because for us, the data we have is for members of NHIF, those who have subscribed to NHIF. Mm-hmm. But what I can say it is malaria is a leading cause of hospitalization and hospital visits. So we are seeing, as she has said, that the trend is going downwards. However, we are not there yet. So we are still spending quite a significant amount of money to cover patients or to cover Kenyans who are NHIF subscribers from malaria and related complications, both at inpatient and outpatient level, with more significant numbers being witnessed in the outpatient settings than the inpatient setting. And to just give a snapshot for the year to date, 2022-2023 year to date, NHIF has spent close to 1 billion for inpatient cases on malaria, and we have spent almost 350 million for outpatient cases. So when you put that together, and this is for people who are NHIF subscribers, meaning there are those who are paying out of pocket, those who are paying through other insurances that whose data we may not have. It means year to date, which is 9 months, we have spent 1.1 billion just to treat malaria, which is a significant amount, because being a disease that can be eliminated, then that money can actually be used to treat other conditions. So yes, the trend is going downwards, but we are still not out of the woods yet.
And speak of which particular counties is NHIF right now targeting mostly? Even as there is a reduction of it, but then which major counties are you really targeting to have the insurance and ensure that the population there is sorted out?
The greatest prevalence is in Western Kenya. That's where we are seeing a persistent numbers of malaria. And when we talk about Western Kenya, we are talking areas around Busia, Kisumu, Kisii, Migori, and all the way to Kisumu. That's where most of the cases actually are coming from. And when we look at the cause of malaria, because the mosquito, yes, is the vector that causes malaria, but we have 3 types of protozoa or which cause the malaria. We have the Plasmodium falciparum, we have the Plasmodium malariae, oval malaria, and we have Plasmodium vivax. So the leading cause of malaria in Kenya is the Plasmodium falciparum. And coast is doing better in terms of malaria, but in Western Kenya, we still have a high prevalence of malaria, specifically around the Lake region.
Right.
Yeah.
Dr. you just talked about there's still a high prevalence, but then which new methods of prevention methods should be taken moving forward, or have been taken and are actually working?
Okay, so recently the one that everybody should be talking about is this vaccine. It's called RTSS vaccine. It was, yes, it is an intramuscular vaccine. Usually it's given in 4 doses to children. It started at 5th month, and then you do 3 doses monthly, and then another dose could be done at 9 or 24 months. That is still being worked on because it's completed. That's the only vaccine we have which has completed the 3 phases that we say of clinical trial. And only after it's completed that and it's shown enough efficacy and safety will then an agency like FDA or EMA is going to approve it, and that's when it will be doled out to the general population, right? So it's being done in 3 countries, that is Ghana and Kenya and Malawi, I think. So in collaboration with WHO, that's where it's been started, and I think the number is close to 1 million children have gotten at least a single dose. And it was started last year, and now it's called phased introduction when they do it slowly. Like, let's say now it's these 3 countries. Now, I think close to 15 to 25 other countries have also applied now, saying that we also want to start this vaccine. So this vaccine is so important because we didn't talk about this, how under 5 children, you see children who are below 5, their immunity is not that great, right? So 2/3 of the deaths that happen due to malaria, it's in children, under 5 children. So that's the reason why this vaccine is targeting those children, right? It's helped reduce mortality by 50%. That is very, very significant. So this vaccine is definitely one such intervention that is helping. Having said that, there is a limitation in that this vaccine is efficacious up to 50%, meaning out of 100 children, 50 will show 100%, being protected against malaria, falciparum malaria especially. Also, the immunity will wane, meaning after 5 years, the children might not be as immune as they were when you gave the vaccine. So there is still a challenge going on. So a couple of other vaccines are also in phase 2, phase 3 clinical trial. They are supposed to come out possibly. So this vaccine is such an amazing thing that Kenya is able to, implement. So it's a good thing that we are heading in the right direction. Apart from that, we have these measures called, insecticide that are filled in the nets, mosquito nets.
Kindly, before we actually get into matters insecticide, speaking of matters vaccines and vaccines in Kenya and even globally, when you mention to someone a vaccine, it's always a hot topic. Basically, still on matters, even the COVID vaccines. How many counties so far has it been rolled out? the
Eight
vaccine?
counties.
8 counties.
8 counties.
What is what are people saying basically? Is there positive?
I think it is convincing them, gaining their trust, plus the fact that they might not trust. You're injecting something foreign in your body. There are these social cultural obstacles that you have anywhere, not just in Africa. I think many countries, even in United States, we saw that people did not want to trust a vaccine, right? So it's education and more evidence coming out when we present the statistics. Like, let's say I've done introduction of vaccine in population, then I do studies and I talk to people where it's someone trustworthy. Like, let's say if it's a rural area, you will need someone who can gain people's trust, educate them, show them evidence that, you know what, it's actually working. Your children can be protected. It's there. What I've seen is some of the socio-cultural behaviors. Like, let's say if a child has fever, how many in the rural area would actually want to go to a health facility? Forget vaccine, they will not even possibly want to take treatment, right? So there is a huge gap there that I think going forward, not just having these strategies, how to implement is the next level now. How we're going to gain their trust, how are we going to make universal coverage of this vaccine? It's a challenge. It's a
Right.
challenge.
Hold that particular thought on matters insecticide.
Yes.
I wanted to get on that later on.
Yes.
And speaking of the civic education, even as I'd love to know what NHIF is doing on matters civic education. But then, Dr. what is there a major challenge in matters civic education in matters malaria? Do people really understand what malaria is basically?
I think there is still lack of complete awareness regarding it to even be convinced that there is a disease. I know some population that they believe it's just some kind of spiritual beliefs that do not advocate that there is actually a parasite. It's a parasite-borne disease, right? That there is a parasite causing it. So you need to possibly more and more education, more and more children going to school, learning that, and then their parents being convinced that there is an actual infection. Malaria is this thing that can be controlled. Mosquito is responsible for spreading it. I think education and information, education, communication, improving, the access to the information that is available. Many people will not bother. Like, let's say if I'm a daily wage worker, am I going to really look at what information is available regarding an infection, or am I going to go ahead, live my life? My stress will be providing for my family, doing my job, coming home. I even remember, I think this was mentioned in one of the articles, where one of the, person who was living in that area was asked, do you feel like you're participating in limiting malaria spread? And that individual ended up saying, it's not part of my problem. I'm not going to engage. How is containing mosquito my duty? So you can see that when people do not participate and do not even accept and do not engage in controlling this, which this disease requires participation at all levels. And if people are not convinced of malaria and they are not willing to follow, it's going to be a big challenge, forget even taking vaccine, to even admit that something needs to be done about it.
Right. Before I get to you, being told that we need to take a short break, and we'll be right back to discuss matters the whole economic costs and all that, and also matters the civic education. You're watching Morning Cafe. We'll be right back. way, and we're discussing matters World Malaria Day, and I do have the sharpest of minds to discuss all of that. And again, the question arises as we discuss matters World Malaria Day. On the whole, civic education, do people really understand what malaria is in the rural areas? And even in Nairobi, by the way, the whole country, do people really understand what malaria is?
In terms of definition of malaria, I think the definition varies from one community to another and from one person to another. And the fact that we don't have a common definition by everyone in Kenya becomes an issue in trying to prevent and to treat malaria. Because from many communities in the rural areas in Nairobi, malaria is more of a syndrome. And how we define syndrome, and Dr. will say here, is a disease that has a lot of correction of symptoms. Mm-hmm. And malaria presents as that. And so when you walk in the village, somebody will tell you, I have malaria in the stomach, I have malaria in the head, I have malaria, here and there. It is not like a disease that someone can point and say, it's like cholera or something like diabetes. So the definition needs to be very clear. And again, the fact that malaria presents with symptoms that are so common in other diseases makes it also very difficult to treat. And that's why it is very critical that diagnosis is made at the early stages, and that all clinical workers are very suspicious of malaria being an issue when a person comes, especially with fever, headache, and everything, sometimes stomachache, because, okay, the symptoms may mimic other diseases like typhoid, but it is very critical. The blood side that is the test for malaria is a very cheap and available test everywhere, from the dispensary level to the tertiary level. It is easy to diagnose, it is cheap, and it is doable. So clinical workers need first to be highly suspicious of malaria, especially for people who live in malaria endemic areas and for people who have history of traveling to malaria endemic areas. And in terms of prevention and control, and what the government and the Ministry of Health is doing is that community health volunteers are going to play a big role in demystifying first what malaria is and being able to get the trust of community, as Dr. was saying, especially in terms of immunization and other prevention measures. Okay. Because community health workers or volunteers are going to be drawn from the community where they live. And as such, they have trust of the people they are going to be dealing with. And that way, they are able to share the information about malaria and other diseases in a language and in a way that is acceptable and understandable to the community that they are living in. And I think with that, we are going to see a sharp decline in malaria, because now people, the way she was saying, socio-cultural issues and religious belief, demystification of those is going to help people know when a child has a fever, don't give traditional medicine, don't take them to a healer or a priest for prayers, take them to the hospital. That test, which costs less than 100, actually 100 to 150, can be done and treatment can be initiated. That way we can prevent, we can actually treat positive cases of malaria. Because remember, the vector is mosquito. So if you have a child or a person who has malaria in the family and they're not treated, they become a source of infection for the other family members, because this mosquito will bite them and go and bite the next person and go and bite the next person, so it becomes a source of infection. Right. So the community health volunteers are going to play a significant role in reducing malaria and actually increasing the acceptability of the malaria vaccine.
I like how you mentioning matters, demystifying it, and Dr. help us, dig deeper into this, because again, as you're saying, each different communities would say, I have malaria for the stomach, malaria for the chest, and all that. What are the main things that people would often confuse with malaria?
Okay, so the symptoms you see in malaria will involve fever and body ache, right? That can happen even with gastroenteritis, meaning my stomach bug, right? Like we say, a stomach bug, food poisoning. what actually is what we need to demystify is this cerebral malaria. I remember Judith mentioning the symptoms you see in cerebral malaria are where the patient or the person is acting, behaving abnormally. Like they're disoriented, they could be talking something funny, or they could not be completely alert. So you're looking at that person and you're not really suspecting malaria because it's not typical to present with, those symptoms, like having hallucinations. Maybe that person is ignored as having a mental illness, right? So, and other symptoms where, like, let's say it's directed at kidney, the person can pass different colored urine. So now you're thinking it's some other kidney infection and not really suspecting malaria. And especially if travelers have gone to malaria endemic area and then come back, the doctors there are not going to, when you come in with fever, they're not going to say, oh, it could be malaria, right? So the symptom presentation has to, you really need to match it with demographic data that is available. Is there high prevalence? Is there a possibility of an epidemic? So those correlations will help you in suspecting that high risk area, there is possibility of malaria, I'm going to test for it. And like Judith said, it has to be at the earliest. Like, let's say if it's falciparum, within 24 hours, if you're not really diagnosing, there are high chances it can progress to cerebral malaria. And once you progress to cerebral, like it's possible with falciparum because it can attach to the blood vessels in the brain and it can gain access, which is why it's so fatal. You could lose the patient within 48 hours because you've been negligent, you did not have all the data, you were not. So these false clinical medical practices can cost lives. So I think that's where we are at.
Right.
Yeah.
Let's talk about nets now. And I think back in 2020, the government of Kenya, the Minister of Health, undertook a whole program to distribute nets to at-risk population. How effective was it so far? And the whole program of distributing nets to at-risk population, how effective is it on its own?
It's supposed to be like significantly effective. Although there have been reports where the population, people in there, they don't know the importance of it, and so they're not making use of it, or they make use of it sometimes, like when the seasonal incidence is high, and then they probably stop using it. But these insecticide-laden nets, they are so important, because even when we are saying vaccine can control it, it has to be done with vector control measure like nets. So when you're using nets, you're limiting the mosquito from feeding. Like their feeding practices, they tend to feed at night when you're relaxing in the house. So I would say using nets can increase any kind of control measure that you have up to 90%. So very, very important that people are made aware of this. They need to understand it's so very crucial and important, along with the existing intervention measures.
Right. Matters, money and all that.
Yeah.
The whole future of, for NHIF in covering communicable diseases such as malaria, how is it looking like?
Malaria, communicable diseases actually in Kenya is something that we shouldn't even be talking about, because communicable diseases are eliminable, can be eliminated in most instances through simple interventions that are cost effective. However, because we've not been able to do that, NHIF is still incurring a significant amount of spending a significant amount of its resources in covering communicable diseases. And as I said earlier, in the year to date, 9 months to date, from July 1st, 2022 to now, we have spent close to 1.1 billion on malaria alone. And that is a significant amount, because if we are saying we are spending 54 billion per year to treat all other diseases, if you just take malaria alone and you are using 1 billion, it is significant. And why it is very significant is because it is a disease that can actually be eliminated through safe practices, like she said, immunization, mosquito, insecticide-treated mosquito nets, dressing. It is very critical how kids are dressed in the evening.
Protective clothing.
To protective clothing, simple things that we can do, clearing the bushes around your houses, ensuring there is no stagnant water around the houses. Very simple but very effective interventions that can be used to save that 1 billion that NHIF is actually using, and it can be used to treat other issues, because we are having what we call a triple jeopardy because now we have to deal with communicable diseases. Now we are dealing with non-communicable diseases, cancer, diabetes, hypertension being the leading, and then we have other lifestyle diseases like accidents. So if we can save this 1 billion, which we are using on malaria currently, we can actually invest in these other diseases that we are struggling with as a country.
Right.
So and again, when we look at financials, we don't just look at what we are spending, but we also have to look at what is the man lost hours in terms of work. Because when a person is sick, it means they cannot work. Those who are admitted are spending an average of 3 days in the hospital. So that is 3 lost working days. Not just for the patient, because remember, when in Kenya, when you have a patient in the hospital, relatives have to come and see. So when you look, we quantify the indirect cost of malaria. What we are paying, it could be double in terms of what the economy is losing because of the lost man hours.
Right.
So if we can prevent malaria, we will be able to save the indirect costs. We are going to be able to save the 1.1 billion which we are using, and which is likely to go to up to 1.5 billion by the end of the financial year.
Right.
And this can be used now to handle other diseases that are now a burden, and that we may not be able to prevent as effectively as we would malaria. Yeah.
Doctor, even as you come in on matters, discussing the role of technology in preventing and ensuring that by 2030 we actually have 0 cases. But then, to clear the air on this, and growing up, word on the street is always that if you wear black clothes, mosquitoes tend to bite you more. If we actually continue, can you clarify for us that? Is it true, by the way? Is it true that if for example I'm here and I'm wearing black, all black, or maybe a piece of black, or maybe my dark skin, I'm quite black, so mosquitoes tend to bite me more. Is that true?
I don't think that's true at all.
Okay.
I think they're mostly drawn to the blood pigments that are carried by RBCs in your body.
Pigments?
The blood pigments,
Okay.
like hemoglobin, hemine pigments. That's the reason why, the malaria parasite, it infects RBCs mainly in your body because it's drawn to those pigments. And I don't think that has anything to do with your skin color, clothing. There have been studies that say some blood groups are more susceptible for the mosquito bites, but yeah.
So it depends on how sweet your blood is, quote unquote.
And depends on how hungry the mosquito is and how many feeds it got before, possibly.
Right.
So, yeah.
But back to matters of technology, how has it so far played? I mean, we're living in a century where we are, shaping up in matters of technology. How has technology played a role in malaria?
There are a lot of promising prospects thanks to development in technology, like you have artificial intelligence and machine learning. They all sound big terms. Even nanobiotechnology, there is gene drive engineering where you're modifying genes. Alongside, we have even drones. Like imagine you need manual labor to spray the insecticide, right? Now we are limiting that by employing drones that are able to spray this insecticide in rice fields and basically limiting the mosquitoes, like trying to limit their movement so that we are reducing the bites, right? Along with that, there is this artificial learning and machine learning that is now focusing on being able to detect the cases. Like imagine you're reducing the time it's taken. Like let's say somebody is in a very remote part where there is no laboratory facility. They are able to make a blood film which will not require the whole laboratory facility. You just have a blood film, you're using a mobile app, and you're taking a picture and sharing that so that diagnosis can be made. You would need a high resolution camera, of course. So you're now reaching a very remote pocket that wouldn't be possible. Like there are no labs, nothing, but still diagnosis is possible. And along with these mobile apps, you're now sharing information. That also helps to know prevalence, incidence, conducting surveillance studies. And not just that, machine learning is also understanding the pattern of, the diagnosis that is there. So it helps us to come up with, where do you channelize resources? Where do I want to put all my resources in, like this area, that area? It is also helping us come with newer drugs. It's reducing the cost and time that would take to come up with newer drugs, because machine learning, they're able to pick up on what's working, what's not working. And funny thing is this genetic advancement that is there everywhere. Imagine you're taking a mosquito, you're modifying the genes within the mosquito so that the offsprings of the mosquito will not be able to carry the parasite.
Right.
How the disease happens is, as mosquito is carrying the parasite and the bite is how it enters. So you're modifying the whole mosquito population with genetic technology.
The question now arises, how blessed is Kenya in all this technology?
I think it is only UN is partnering up with developed countries. I think with Kenya, it's difficult. I think it's something Department of Public Health will answer, but it's difficult. Do we go for automated ones, or do we focus on the existing intervention strategies that are yet to fully reach their optimal potential? Do I go for something new that is expensive, or do I fulfill whatever is working right now?
Right.
So I think the best way forward would be to optimize what currently we have, the strategies. And then when the other countries have had success with it, that's when we possibly, invest in it.
Basically focusing more on preventive rather than curative. And to wrap up this particular conversation, what is NHF basically doing to focus more on preventive rather than curative on this?
Thank you so much. The repealing of the Act, the NHIF Act of 1998, which happened between 2020 and is now in implementation, has widened the scope that NHIF has in terms of interventions they can actually fund and participate in. Up to 2020, NHIF stood for National Hospital Insurance Fund, which actually restricted NHIF activities within hospitals.
All right.
Meaning we were more focused in issues curative. But now the NHIF currently stands for National Health Insurance Fund. The health word has given us a larger mandate and a larger operating environment, because now we are not only tied to the hospital. In our benefit package, when we talk about the benefit package in terms of outpatient and inpatient, one of the critical roles in the outpatient benefit package is health prevention and health promotion. And this is an activity that every facility that is accredited and contracted by NHIF should participate in terms of reaching out to the communities in which they operate, to ensure they are participating in health promotive and health education activities, because education is very critical, especially for communicable diseases, because they can be prevented through just education, when you know what you need to do to prevent yourself from getting malaria. But apart from that, the Ministry of Health and in the runner-up to UHC, which the government is very keen about, the role of the public health, the role of county governments, and the role of CHVs, as I talked about, the community health volunteers, has been very well defined in terms of ensuring health promotion and health and prevention is not a haphazard activity, but it is ingrained, it is enshrined in what is mandatory for every county, for community health volunteers and for NHIF. So in designing the benefit package, both for the UHC and for NHIF, beneficiaries as it is currently, health promotion and health education finds a very central role, because we understand that by prevention and health promotion, we are going to be able to deal with a lot of communicable diseases, not just malaria, but also diarrhea diseases and other diseases. Mm-hmm. So we are trying to incentivize and decentralize that role to the community level. And that's why the government is very keen in employing community health volunteers, so that they can actually activate that that role or that function
Right.
from the community level. And as I said earlier, the community health volunteers are going to be people who can speak in your dialect. So whichever name you give to malaria in your dialect is what they will speak to you. Because for me, when I come to you, I'll speak to you in Kiswahili and English. You may not understand. But when it is put in a dialect that you can actually understand, it actually, touches the nerve. And
Yeah,
it
definitely.
makes sense for you
Yeah.
that this is what I need to do. So the government is investing a lot in terms of community health volunteers, the role of tier 1, tier 2 health facilities, which are dispensaries and health centers, to be able to actually drill and cascade this information about prevention and promotion down to the community.
Right.
Yes.
Ladies, allow me to take your parting shots on this conversation. But then, as you do, also speak on this year's theme, which is time to deliver zero malaria, invest, innovate, and implement. As you deliver your parting shots, do you feel like how best can we actually achieve this theme for this year? I'll start with you, Dr.
So you would have to stratify at each level what their responsibilities are. And that's how best you can achieve cooperation between multiple levels, right? Like there is at community level, you're telling them, you're educating them that at the sign of fever and when they're suspecting it, they go get help. At the health facility level, you make available these microscopy and rapid diagnostic kits. And not just that, other, like if they insecticide nets, and you're also making stocks of medication available at health facility level, that at sub-county level, you're surveilling and gathering data of what the trends have been, what are the months when you have the highest prevalence, and that at county level, how best are you making use of all this information, how best are you engaging resources at each level, and how are you training? Because it's all about capacity building, you're having trained, skilled workers that you need. Otherwise, we're going to miss out on diagnosing critical cases, right?
Okay.
So it's cooperation at all these levels that's going to help us achieve. I think if we do all of this at 90% efficiency, then definitely Vision 2030 is possible. So yeah, just keep working hard and we should reach there.
I love that. Judith.
Yeah, for me, my parting shot is like delivering zero malaria is everyone's business. It's for everyone's business, from the mama mboga, the mama in the village, to the policy level, to the
Absolutely.
government, because government commitment is very critical in terms of drilling down what the government wants to achieve. We are losing a lot of revenue. We are losing economically through avoidable diseases like malaria. So if everyone can actually play their role, as they said, and everyone's business becomes that we have to defeat malaria, then as Kenya, we are going to defeat malaria. And we can become a case study for Africa that it is doable, it is achievable, and Kenya has actually learned, like we lead in other things, Kenya will lead this way. So we need to engage every person, and every mother should be taught when they go to the antenatal clinic, when they go for immunization clinic, how to be suspicious about malaria. Healthcare workers have to be taught how to be suspicious about malaria, and everybody in the community need to be suspicious, so that we have a shared vision and a shared goal of eliminating malaria.
Okay.
And I think 2030 could even be far. I think we can actually do it faster than 2030.
Hopefully, if all stakeholders
Yes.
join hands and actually fight
If we make
and
it-
help in the whole fight against malaria.
Yeah, if we make it everyone's business, we
Okay.
can achieve it faster. We can accelerate the
Right.
achievement of zero malaria.
On a lighter note, I think one mosquito just bit my neck right now.
We should get a rapid diagnostic kit.
after this particular show. Thank you, ladies, by the way,
Absolute
for
pleasure.
really. I think after this, up to this point, I've learned quite a lot of matters concerning this particular topic, and we'll definitely be discussing this particular topic as we go on. Dr. Suma Kulkarni, General Practitioner, White Oak Medical Center, as well as Judith Otele, Case Management Manager at NHIF. Thank you, ladies, very much for your time.
Thank you.
All right.
And tell Kenyans to enlist with NHIF.
All right.
It is critical.
We definitely have to have you back here again because there's so many questions when it comes. There was actually an article on matters in HIV. I don't know if it was the Daily Nation or the Standard, but then because of time, I won't get into that. There's a whole other murky world on matters, pull and push on matters in HIV. But then thank you very much. And thank you too for joining us on this particular conversation on matters NHIF. And as the experts say, it is definitely your business to ensure that by 2030 or even before, there are